All right. So again, welcome to 2025, our first topic, newer treatments in migraines. And I'm your host, Dr. Ronak, and let's begin with some of the key things with migraines, right? So I like a highly interactive session, all right? And in my session, usually I ask questions and I expect answers from you guys, right? So the more you interact, the more you retain information, I feel. So we have a chat box in Zoom, and what I would like you guys to do is type into the chat box. Okay? So migraine. So pathophysiology of migraine. Why does migraine actually happen? Anyone knows? Can you type in? Give me some indication. Why does migraine happen? Type into the chat box. Why do you think? Okay, vasodilatation, the vaso. Okay, all right. So, well, I forgot about our French folks over here. So, bonjour tout le monde. Okay, and bienvenue to our class. That's my French. All right. Okay. Due to sudden vasodilatation. Okay, good, good. Hormonal imbalance. Okay. Okay. So all our life we have thought that migraine primarily is something related to vasodilatation, right? Well, migraine, the pathophysiology is very complex, right? Hard to pinpoint that this is the only reason for it versus others. Okay. So major reasons why migraines happen is because of neuronal firing. Everybody agrees? Our nerves start firing randomly, right? A lot. And because of the nerve firing, a lot of our structures in and around the head get affected and we get migraines, right? So one of the pathways for that, right? One of the pathways for that is your CGRP, your calcitonin gene related peptide pathway. So what happens is anytime you have a trigger, okay, for a migraine. So give me some examples. What are some of the triggers for migraines? What causes a migraine? What are some of the triggers? Stress, right? MCCQE1 examination. What is the trigger for migraine? MCCQE1. I'm joking. But yes, stress causes that. Certain smells can cause it, right? What else? You can have chocolates, right? Chocolate, wine, cheese, coffee. How many people over here have had like drink tea or coffee regularly, and the time that you don't have it, you start getting a migraine, right? So very good. Chocolate, wine, cheese, right? Sleeplessness, all of these guys. That, yeah, there you go. Menstruation, very good. Okay. So very important. Female women's health, right? Premenstrual or menstrual migraines, right? A lot of these are the triggers for it. Okay. Yes, very good. Abdominal migraines, kid, right? Very good. So very, very important. These are the different types of triggers for migraines. So what happens is anytime you get a stressor or a trigger for a migraine, right? It goes and affects your trigeminal nerve branches and pathways. Why? Because out of all our cranial nerves, trigeminal is the one that supplies most of the head, right? The sensory supply, a lot of it is trigeminal nerve. So these triggers and stressors through complex mechanisms affect these. And these neurons start firing. When these neurons fire, they release these active neuropeptide called calcitonin gene related peptides. These neurons release these peptides, right? And these peptides then go and cause multiple things: vasodilatation, release of nociceptive, whatever, receptor triggers, and all of those things, dura mater crap, and all of that, these CGRP causes. So, what do? We can give some medication which can block the CGRP. Okay. And nowadays, there are multiple medications that can act on these systems. So we'll talk about some of these, we'll clear some of the doubts out and move forward with it. But does MCCQ even ask specifically about pathophysiology? No, they don't. Okay. So the 5 minutes of the lecture that we spent so far was more FYI. Okay. Now let's talk about examination related stuff. So, simple thing, 22-year-old female comes to your office because she has been having these headaches for last 2 to 3 months. Her dad also struggles with headaches at times, right? You have a simple case like that. So what are we going to do? We are going to evaluate the headache itself, right? This is the headache in office. So we are going to evaluate the headache. So we are going to say, okay, you know what? Let me think about some of the things associated with the headache and differentials associated with it. So tell me some differentials of headache in office. What are some of the differential diagnoses? Very good. Tension headache, right? Important stuff. Tension headache. Are you in tension? Yes, you have a tension headache. We have migraine. Good. We have cluster headache. Good. Right? These are some of the key things, right, for headaches. And then you have other ones like medication-induced headache, medication withdrawal headache, trigeminal neuralgia. Those are some of the other types of headaches that come in. Okay? So these are the major ones. Now for migraine, there are specific short form acronym mnemonic that we follow. What is that? That is called your pound. Okay, for pound. What does this mean? P is pulsatile. What does O mean? This is the mnemonic for migraine. Migraine headache is pulsatile. People often say it's throbbing. Onset, okay. Sudden onset, gradual onset, migraine. It's not ocular, it's just onset. Okay. Very good. What about U? What is U? Unilateral. So usually migraine is unilateral, not bilateral. What is N? And you can have associated prodromal stuff like nausea, vomiting, those sorts of things, right? And what is D? D is any guesses? Drugs? Drug? Diurnal? Diplopia? Dead. Disability. Okay. So this is a mnemonic for migraine. Main thing in this mnemonic that you have to remember is that usually migraine headache is pulsatile. It is usually unilateral and has some sort of prodrome at times. Not all headaches have prodromes. Sometimes it has a prodrome such as nausea, right? And also you guys yourself would have noticed as well that anytime there is excess pain and things like that, many times there is nausea, right? Like people get severe abdominal pain, they feel nausea. Many times, if there is like labor pains and stuff, there's nausea. So pain sometimes induces nausea. Okay, good. All right. Red flags. So let's talk about some of the red flags. So anytime, again, somebody had mentioned before meningitis and things like that for differential diagnosis of headaches. So you have a patient that comes in your office, 29-year-old female comes to your office with headaches for last 3 months, right? What is most important for us? Most important for us is to rule out some of the red flags. So systemic signs. So anytime somebody comes in with like fever, rash, what differential are we thinking? Fever, rash, headache, which is really, really bad, all of those things. You recently had upper, very good, meningitis, right? Meningitis, we are thinking, right? So make sure that we rule that out, okay? What if somebody comes and says that I have headaches at night? vomiting, projectile vomiting in the morning. What about that? What are we thinking? Headaches at night, project. Very good. There's some sort of mass, right? Increased intracranial pressure. It could be a tumor. It could be malignancy, anything like that. Good, good, good. What if the patient says that, well, I have slurring of speech and then numbness and tingling on the left hand side of my body and things like that. It could be TIA, it could be stroke, something like that, right? One of the red flags. Everyone agrees? Are these red flags that we can think of? Yeah? Good, good. Somebody who is completely normal for their life, right? Like I have nothing. And suddenly a 65-year-old comes and says, these headaches are bugging me, doctor. These headaches are bugging me. Is that a red flag? Do we need to investigate if somebody just comes in with a new headache? Yes, we need to investigate, right? Good. What else? Papilledema, visual blurriness and stuff. You take a look and you find papilledema, increase intracranial pressure and things. And what's the last one? Last P, Snoop. Last P is pattern change, right? So I was getting these headaches like this for all my life, and now they have changed, right? What do you mean? Before, like they were like throbbing and associated with some nausea. Now I'm getting more and more at night. It's not throbbing anymore. It's like dull aching, and sometimes it's sharp as well. Okay, change in the pattern. That's a big red flag over here as well. Okay. So these are some of the key things to take a look at when you're reading an MCCQ question, right? So remember, guys, this is not a lecture on migraine and how do you improve migraine and stuff. This is a lecture primarily on identifying these things on QE1 questions and stuff. Okay, good. All right. So these are some of the red flags that we have talked about. Now, talking about some of the management stuff. So let's go through the case again. 29-year-old female comes to you with a headache, right? So you have made sure that it's not cluster headache. You have made sure it's nothing else. You have ruled out all the red flags and stuff like that. And now asking the history, the pound in mnemonic and all of that. You do a full physical examination, make sure that there is nothing going on neurologically, and then you decide that okay, this looks more like migraine and things, right? So you say like, all right, let me start treating you with something. What would you treat them with? What is the treatment of acute migraine? Very good. Very good. NSAIDs, right? Something simple. Take an Advil, right? Or take aspirin or something like that, right? So very simple. First line, NSAIDs. Patient says, doctor, I have taken Advil. It does not work for me. I have taken naproxen. It does not work for me. What else can you try? What else can you try? Okay, then there we have triptans, right? We have triptans. Good, triptans. So we can consider very good, Dr. Mariam. Triptan is abortive, absolutely. So we can consider triptans as well. What else? Ergotamines as well. You can consider. Do we use ergotamines a lot nowadays? No, right? We don't. Why? Because we have good efficacy, good low side effect rate, and all of that with triptans. So we usually give triptans, and it works usually well in people. So we can give triptans to them. Now, what are some of the contraindications and side effects of this triptans and things like that? Anyone knows? Like, oh my God, can you give it in pregnancy? We can't give it in pregnancy, right? So, what are some of the other major contraindications of triptans? So, pregnancy is one. Okay, everyone knows that. What else? SSRI, OCP. What about very liver disease? What about somebody with like a cardiovascular disease, somebody who has had like multiple heart bypass and stuff like that? Can we give triptans in them as well? Right? We have to think about it, right? Like it's not like, oh yeah, sure, let's just go for it and stuff like that, right? Like you have to think about it. So cardiovascular history, pregnancy, those are like some of the big things with triptan that we can consider, right? Okay, good. So triptans, ergots, all of that. Now, let's say the patient says, doctor, you are a magician. Okay? Says, doctor, you are a magician, you are a miracle person. Because of you, my headaches now improve when I take triptans. The only problem is I get headaches three times a week. So now what do you have to think about? You have to think about, very good, Dr. Huma, you have to think about prophylaxis, right? You have to think about prophylaxis. So we come to criteria for prophylaxis. In which cases will you consider prophylaxis for migraines? If somebody says, Doctor, I get migraine once a year, will you give them prophylaxis? Yes, no, yes, no? No, right? No. So do you guys know the criteria for prophylaxis? Q1 stuff. Very good, Dr. Huma. 3 episodes or more in a month? Absolutely. What else? Good, good. There are no contraindications. Extremely debilitating. Very good. Okay. So Toronto Notes has it. Multiple other resources have it. Take a look at the criteria for starting prophylaxis of migraines, and then you will know. All right. So now we decided that we will give prophylaxis in migraines. What medications can we give for prophylaxis in migraine? Propranolol. Okay, let me rephrase my question. What medication group can we give for prophylaxis in migraine? Okay, so beta blockers, good. Calcium channel blockers, very good. Tricyclic antidepressants, very good. Anything else? We have three groups so far. BCT, beta blockers, calcium channel blockers, tricyclic antidepressants. Anything else? And very good, very good. Anticonvulsants, right? Anticonvulsants. We can give SNRIs as well, absolutely. Anticonvulsants, gabapentin, topiramate, all those you can give, right? What else? Anything else? What about ACE inhibitor receptor blockers like candesartan and stuff like that? Can we give that for prophylaxis? Have you guys heard of that? Ah, very good. Yes. You can give ACE inhibitor receptor blockers, right? ACE inhibitor receptor blockers. Very good. So those are those as well you can give. Good. Okay. So let's talk about it. Acute attack of migraine. Usually you give NSAIDs, triptans, ergots, those sorts of things. Quite a bit of contraindications with triptans and ergots like pregnancy and angina and MI and anything vasospastic, right? Like peripheral arterial disease, which is a contraindication. Migraine, acute attack in the emergency department, usually there's a whole cocktail for it, right? Ketorolac and IV fluids and all of that. Good. We talked about migraine prevention. So that included anti-epileptics like topiramate and valproate and stuff like that, beta blocker, antihypertensives, right? Like candesartan, calcium channel blockers and stuff, and then antidepressants and gabapentin and stuff as well. Good. Okay, now let's talk a little bit about newer treatments in migraine. So, Dr. iPhone 113, what can we give in pregnancy? Very good question. Okay, I know few things that we can give in pregnancy. Why don't you take a look and then paste it in our group? Okay, so that will be homework. What is the treatment in pregnancy? What do you like a can pregnancy worsen migraines, everyone? Can pregnancy trigger like worsening migraines? Yes. Yeah, it can. A lot of patients are pregnant, their migraines worsen, right? So what can we give in those cases? Why don't you guys find out? Paste in the group and let me know. And then I'll tell you which ones are we actually doing over here, right? Because books will say 5 medications, but in practice we might be doing few. So I'll tell you about that. Good. Okay. Newer treatments. So these are some of the newer treatments. So there are for acute migraines, there are Ditans and lasmiditan and stuff. It was not available in Canada when I had checked. So it might have changed, but I haven't seen it yet, right? It can be. Other things like Japan's, right? Ubro Japan, Rimed Japan, all of that. Have you guys heard of these ones? A Brevi or something like that, a Brizvi or something. It's like Ubro Japan, Reme Japan. Yes, no, yes, no, no. Okay, so these are the newer treatments in migraines. What else? This answers the question. What can be used in cardiovascular disease when triptans are contraindicated? So your Ubro Japan, Reme Japan, you can consider in people who have cardiovascular disease, right? You can think about it. You can consider in people with that. Prophylaxis, you know, what is the weight loss medication that is in fashion right now? Everyone, what is a weight loss medication that is in fashion right now? Ozempic, right? Ozempic. It's like, are you on Ozempic? No? Oh, you're not in fashion. Well, it's Monjaro. Oh my God, right? So those are the medications in fashion, right? Weight loss medications. Okay. So in the world of medicine, right? What class or what group of medications are in fashion right now? Do you know what class or group of medications are in fashion right now? They are the monoclonal antibodies. Okay. They are the monoclonal antibodies. It's like, I have asthma. Well, we do have monoclonal antibody for you, Xolair. I have Crohn's disease. We do have monoclonal. I have ulcerative colitis. Do have. I have rheumatoid arthritis. We have for that. What about psoriasis? We have for that as well, right? It's mental. Multiple sclerosis. Like, yep, you name it. It's like, I have pneumonia. It's like, yep, we have monoclonal antibody against Streptococcus pneumoniae. Your white blood cells don't have to do anything. We will give you external antibodies that will go and destroy the bacteria. It's like, what? Now my white blood cells are on vacation? It's like, yeah, they don't have to do anything. I have flu. It's like, we have monoclonal. Well, we are not at that level yet. Okay. Eventually, hopefully, we will be. But that is a fashion. Okay. That is monoclonal antibodies are taking over the world. And these are the monoclonal antibodies for migraine, right? Erenumumab, um, fremanezumab, eptinezumab, and so forth. What is one good thing about this? That these monoclonal antibodies, right, are 1 month to 3 monthly injections, right? Are 1 month to 3 monthly injections as well. So it's very good because compliance rates can be significantly high with these sorts of monoclonal antibodies. Sorry, with these sorts of treatment dosing, 1 to 3 months, compliance rates can be pretty high. Okay, so let's pause here. All right.